Hello, everybody, and welcome to part 6 of our internal medicine review questions. Now, I did a lot of these medical review questions quite a few years ago, and I kind of want to get back to them because this is really foundational for your medical licensing examinations. And yes, I do intend in the future to do some psychiatry and pediatric and OB review questions. But like I said, this is really foundational. If you're taking step 2 or step 3 or various other medical licensing examinations in other countries, you're going to find that internal medicine is going to consume the lion's share of your questions. And so you really need to have a good foundation here. And, really, as you go through your rotations, what you'll find is that if you have a good foundation in internal medicine, it will help you, particularly for surgery and also to some degree for pediatrics and OB. So it's good to get your foundation set here first, and then it will help you approach some of the other questions. So we will start here. And it's really nice that now, unlike my previous sets of review questions, I can write on the slides. And so that makes it a little bit more convenient. If you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or on the I button on the upper right-hand corner. I very much appreciate all the contributions that I can get to help offset the cost of these videos, and I thank all those of you who have already donated. All right, let's start out with this first question here. We have a 51-year-old white man who is brought to the emergency department by his wife with worsening abdominal pain and confusion over the last 36 hours. His wife says that he has a 20-year history of alcoholism and has been treated in the past for water on the belly. He has been more sober than usual for the past 2 years, but still occasionally binge drinks. Physical exam reveals palmar erythema, spider angiomata, and a fluid wave. He's somnolent, but groans when his abdomen is palpated in all 4 quadrants. There is no rebound tenderness. Stool occult blood is negative. Vitals, blood pressure 100/67, heart rate 90, respirations 21, temperature 100.9. Notable labs include an elevated white count with a left shift, sodium of 131 milliequivalents, albumin of 2.9, INR of 1.8, and liver enzymes within normal limits. Paracentesis is performed and reveals an albumin of 2.0 and a white count of 800 cubic millimeters, or 800 per cubic millimeters, and 50% of those white cells are neutrophils. Which of the following is the best next step in the management of this patient? A large volume paracentesis. B, referral to surgery for transjugular intrahepatic paracentesis. C, IV 3% sodium chloride infusion and fluid restriction. D, IV ceftriaxone and albumin. Or E, referral to surgery for laparoscopy. And as usual, I'll give you some time to pause as you consider the answer to this question. Remember, on step 2 and step 3, you'll have roughly 1 to 1.5 minutes per question, but you kind of want to go a little bit faster so you have time to review. Okay, so our answer here is D, IV ceftriaxone and albumin. So what does this patient have? He has a fever, he has ascites, and he has some confusion. And this is most likely spontaneous bacterial peritonitis. This is a complication of ascites, and ascites is a complication of cirrhosis. Now, how do we know he has cirrhosis? Well, he has liver symptoms with a history of alcoholism, so that is probably going to be cirrhosis. And when you have ascites, anytime you have ascites, there is a risk of peritonitis, of spontaneous bacterial peritonitis. So why does this happen? This happens because of seeding from the gut, from the intestines, which then gets into the acidic fluid. The acidic fluid is nutrient rich, and that can trigger the proliferation of bacteria, which then causes infection. This is a serious complication. It can be deadly. And so what we see here is actually symptoms both of liver failure, but also symptoms of a significant infection. So that is going to point us towards spontaneous bacterial peritonitis, or SBP. Now, why are these wrong answers wrong? Well, let's look at A. So, large volume paracentesis. Now, we may do this on this patient. Notice that his respirations are 21. If this ascites continues to get worse, it's going to push up on the diaphragm and the lungs, and it's going to make it difficult to breathe. And so, to relieve those symptoms, we will draw out some of that acidic fluid. But doing that right away before treating the peritonitis is going to drop his fluid, and that can result in renal failure. So we don't want to do that just yet. We need to treat the SBP first. B, tips. This is something that may be done eventually, but when he's healthy. We're not going to do surgery when he's got a belly full of fluid. IV 3% sodium chloride infusion and fluid restriction. This would be done if the patient had symptoms of hyponatremia. Now, he does have some symptoms that may be consistent with hyponatremia. That would be the confusion, for instance, the altered mental status, but that is more likely due, in this case, to the infection. So if he were having seizures or something like that, we would consider that. But again, the altered mental status is most likely due to an infection. And then E, referral to surgery for laparoscopy. Your surgeon will laugh in your face if you ask them to stick a laparoscope into a belly full of acidic fluid. And when I say acidic fluid, I am not talking about acid. I am talking about fluid related to the ascites. So we do IV ceftriaxone and albumin to treat the infection and also to get more protein into the intravascular space. Remember that what happens with this particular kind of ascites is that you have a low concentration of albumin in the blood and a low concentration of albumin in the blood. And what's going to happen then is you're just going to get osmosis. So this is very similar to how edema happens, like peripheral edema. When your serum albumin drops, water is going to leave via osmosis and go into the extravascular space. And the peritoneum is one of those extravascular spaces. So by providing albumin to the patient, it's going to reduce that transudation. So the diagnosis here is SBP. The triad is worsening ascites, fever, and abdominal pain. This is often associated with confusion and altered mental status. Now be very careful here. You need to, if you're considering the possibility of hepatic encephalopathy, you need to look for other signs, namely asterixis. And we do not see that in this patient. What we do see is abdominal pain and a fever and ascites, and that is much more consistent with SBP. Could he have both? Sure. But the more pressing issue here is the SBP. He could easily become septic and die. So we need to treat that first. When SBP is suspected, the best initial step is a diagnostic paracentesis. That could be a question. So if it didn't say that we did a diagnostic paracentesis, we didn't have those numbers from the acidic fluid, then that would be your best first step. And the USMLE may confuse you by saying diagnostic paracentesis and large volume paracentesis. Make sure you are going for the diagnostic paracentesis because we need to know the etiology of this ascites because there are multiple etiologies. Now, one of the things that you're going to do when you get that diagnostic paracentesis, you're going to look at two things. You're going to look at the albumin level of the acidic fluid, and you're going to look at the cellular contents of the acidic fluid, particularly the white count and whether or not they are neutrophils, which there will be some, but the extent to which neutrophils are present. So basically, this is just a mathematical equation. We take the serum albumin and subtract the ascites albumin. Okay, so what we would expect to see if the serum albumin ascites gradient or SAG gradient is more than 1.1, this is a transudative effusion. And it makes sense, right? If you have a low albumin in your acidic fluid, it means it's mostly water being pushed out, not so much protein being pushed out. Whereas if it's less than 1.1, it means that this ascites albumin is higher, and that would mean that you have an exudate, and there are multiple causes of an exudate. Now, a transudate is usually going to be from portal hypertension. Now, that can be due to a variety of causes, namely, it could be prehepatic or intrahepatic, or it could be posthepatic. Think of things like congestive heart failure or a pericarditis, for instance. Now, one of the ways that there are two ways that you can diagnose SBP. Number one is you can get a culture, and you will always get a culture because we need to know the bacterial etiology and the sensitivities. But as you know, cultures take a while to come back. We're talking on the order of days. So another way that you can do it is to look at the neutrophil count. Now, this can be difficult, but you just need to use some math. So all you do is you take the white blood cell count, which will be given to you in cells per cubic millimeter, and you multiply that by the percent of neutrophils, and you'll get a number. And if that number is equal to or more than 450, you have a diagnosis right there. Okay, so that's fairly simple. So if it's more than 450, equal to or more than 450, then you have SBP. So the best initial step in management upon diagnosis of SBP is going to be an antibiotic and albumin, and we go for a third generation cephalosporin. The most common is ceftriaxone, but you can use one of the other ones if you so desire. Now, there is something that does come up, particularly on step 3. A lot of questions on step 3 like to go after what is this patient's prognosis? That is something that kind of separates step 3 from step 2. There's a lot of overlap, but step 3 likes to ask, what's this patient's prognosis? Because you're going to need to talk about that with patients. And so one of the ways that we can figure out what the prognosis is something called the MELD score. Now, you don't need to know how to calculate the MELD score. I don't even know how to calculate it, and I do this quite frequently. You plug it into a computer, but you need to know what the MELD score incorporates. And it incorporates 4 things: serum sodium, which is relatively new, added onto the MELD score, serum creatinine, serum bilirubin, and the INR. Now, notice here, the INR is a function of liver function. It's part of your liver function because you make clotting factors in your liver. So a question that you may get on the step is, which of the following factors, not clotting factors, which of the following factors is most tied to this patient's prognosis? And it may give you serum ammonia, PTT, and various other things. And one of these will be on there, and that will be the right answer. So this is the MELD score, and it gives you a percent mortality in a given period of time. And so you should be familiar with it. Okay, so this is my approach when I have a patient with ascites. The very first thing that you need to do is a diagnostic paracentesis. Of course, before you do that, or as you're waiting for the equipment to come, you're of course going to be getting CBC, CMP, which remember includes your liver function tests and all that stuff, blood cultures and stuff like that. But USMLE is not going to ask you what's the best step. Oh, it's a CBC. They're going to ask you what's the more unique best step, if you will. So yes, you're going to get routine labs, but the most important next step is a diagnostic paracentesis. Again, make sure that you are selecting diagnostic paracentesis and not large volume paracentesis. So the very first thing you can look at is what's the neutrophil count? Because if the neutrophil count is 450 or more, then you've got your diagnosis of SBP, and you'll go for ceftriaxone and albumin. Okay. Next, you want to look at that seg. If it's 1.1 or less, then what you're dealing with is a portal hypertension. What you can do at that point is look at the acidic protein. If it's less than 2.5, you're dealing with something pre- or intrahepatic. That could be cirrhosis. Cirrhosis makes up about 80% of ascites cases, so that should be the first thing on your mind. It could be from liver metastases, which would occlude the vessels in the liver, or it could be a late manifestation of Budd-Chiari. If it's 2.5 or more, what you're likely dealing with here is a cardiac origin. So it could be congestive heart failure, it could be constrictive pericarditis, it could be an IVC obstruction, or it could be Budd-Chiari. The next thing that I would do if I was thinking of a post-hepatic etiology would be to get an echocardiogram. Now, if the seg is more than 1.1, then what you're probably looking at is an exudate. So leaky capillaries, or you may be dealing with something very important, which we'll get to. A nephrotic syndrome can do that. Peritoneal carcinomatosis can do that. So if you're dealing with a woman with an ascites with fluid in the peritoneal space, you really need to think of ovarian cancer. So make sure that you're doing a bimanual exam, get an ultrasound. It could be due to pancreatitis due to widespread inflammation or biliary leak. But number one thing that should be on your mind when you've got a patient with ascites is a cirrhotic etiology. And of course, there are a number of causes of cirrhosis. All right, let's move on to question 2. Which of the following people do not require further workup for tuberculosis? A, an HIV positive person with a PPD, i.e. a Mantoux test of 9 millimeters. B, a prison inmate with 8 millimeters. C, a person with no risk factors with a PPD of 11 millimeters. D, a healthcare worker at 7 millimeters. E, a person on long-term steroids at 4 millimeters. F, all of the above. G, none of the above. H, both A and E. Or I, both B and D. Okay, USMLE does require you to know this. It's a pain in the butt because you will never do this. Nurses will do this. They are usually the ones who will interpret these, but you do need to know how to do this. Okay, so our answer here is A, an HIV positive person with a PPD of 9 millimeters. So there are 3 cutoffs. One is more than 5 millimeters. That tends to be sick people or close contacts of somebody diagnosed with TB. There's more than 10 millimeters. That tends to be people with very high risk factors, like being a healthcare worker. And then there's 15 millimeters, and that is the general public with no risk factors. Okay, so as we can see, so we'll go over here. The cutoffs, more than 5 millimeters is going to be, like I said, sick people and close contacts of those with active TB. Also, steroid users, they tend to be immunosuppressed because of the steroids, and then people who are immunosuppressed, so people with congenital immunodeficiencies, for instance. That could also include people on anti-transplant medications. More than 10 millimeters are going to be the people with high risk factors. Okay, so this is how I like to think of it. More than 5 millimeters, sick people or close contacts. More than 10 millimeters, people at very high risk. So people from endemic areas, healthcare workers, that's a big one because that's going to constitute most of the people. Healthcare workers are always getting these tests done, usually like every 2 years or so. Homeless people, people in shelters, people in long-term care facilities, prison inmates, and people with chronic diseases. And then more than 15 millimeters is people with no risk factors. So we look here, HIV positive person, that's more than 5 millimeters. This is 9 millimeters, so that's the right answer. So this is just memorization, but you can memorize all these things if you want. But like I said, more than 5 millimeters, think of sick people and close contacts. More than 10 millimeters, think of people who have high risk factors. And then more than 15 millimeters is people with no risk factors. Now, when you get this Mantoux test done, you go in and have the it's a subdermal injection. Most of you have probably had this done before. The induration, pretty much, if you're going to be negative, it's going to go away really fast. But then you have to get it read. But if you do have an induration, make sure that you're measuring it perpendicularly to the arm. Usually it's done on the arm. So that's going to be important. But like I said, if you are a provider, you're probably not going to be actually doing that, but it does come up on your exam. Okay, question 3. We have a 19-year-old man who calls your office complaining of a headache, nausea, and dizziness after some weightlifting at the gym. 3 days ago, he was seen in the ED after sustaining a head injury on the football field and was diagnosed with a concussion. He was told to rest at home for 2 days before returning to any physical activity. You inform the patient that he should be seen in urgent care, where you examine him and find that he has normal vital signs and a normal physical exam. Which of the following is the best next step in the management of this patient? A, head CT, B, brain MRI, C, reassure the patient and recommend that he continue the activity but no contact sports for now. D, reassure the patient and recommend he abstain from activity for a week. Or E, reassure the patient and recommend he abstain from activity for 1 to 2 days. Okay. So this requires you to know a little bit about concussion protocol. And the answer is to reassure the patient and recommend that he abstain from activity for 1 to 2 days. So like I said, concussion protocol. I kind of gave you a little hint when I said that it was concussion. So I put it in the question. You can expect that on your step when they ask you these questions, because you have to know that it's a concussion. Just knowing that he has a head injury is not going to tell you that he had a concussion. You can get hit in the head and not have a concussion. So what this question requires you to know is concussion protocol. So let's talk about that. But first, let's talk about what a concussion is. So concussion is a traumatic brain injury, a mild traumatic brain injury that's caused either by a direct blow to the head or by deceleration of the head from an impulsive force, so basically running into something, that results in a change in mental status. Okay, so it's not actually called a concussion anymore. It's called a mild TBI, but you'll see the word concussion thrown around quite commonly. The most commonly reported symptom is a headache, which may worsen the day after injury, but generally just think of altered mental status. So confusion, headache, and so forth. So when you've got a patient who sustained a head injury and they're confused or they have a headache, what do you got to do first? You got to rule out the life-threatening things, namely a bleed. So the first thing that you're going to do is you're going to get a head CT. Of course, you're going to do a physical exam and look for things like papilledema and focal signs, but you need to get that head CT to rule out a bleed and to rule out bony injuries of the skull. So we're really looking for epidural and subdural hematomas and bony injuries, and that's very easy to rule out on CT. These things can be deadly, so you have to rule this out, and a CT is very easy to get. Concussion is really a diagnosis of exclusion. So this is the post-concussion protocol. Now, there are a variety of protocols. This is the one that we use at my facility. So there are steps, and these steps are taken day by day. So day 1, day 2, day 3, day 4, day 5, day 6. So step 1, after a person has a concussion, you're going to advise them to rest completely for 24 to 48 hours. Now, that rest includes both physical and cognitive rest. So don't be reading books, don't be watching TV, looking at a screen. A light screen is not going to help you. So just bed rest, dim lights, and so forth. And it only needs to be done for 1 to 2 days. Then we start gradually ramping up our physical activity. So some light aerobic exercise, taking a walk around the block, then some sport specific exercise. So if you play hockey, for instance, you can get out and skate, but really nothing more than that. Then step 4 is going to be non-contact training drills. So that means that you can do your practice, but no contact, no physical contact. Then step 5 is full contact practice. So that means you can do your regular practice, but not a game yet. And then step 6 is to return to sport or normal activity. Now, a lot of people who sustain concussion don't play sports, so you can kind of skip some of these. But this is what I would use here. Now, I have seen rest, light activity, moderate activity, and then regular activities. And this is, again, day by day, 1 to 2 days or whatnot. Now, the way that these questions get asked is you've got a patient who had a concussion. They may ask you, what's the best next step then? And that would be rest for 1 to 2 days. Or like in this question, what they may ask you is, okay, you've got a patient who they sustained a concussion a couple days ago. Now they are engaging, let's say, in moderate activity, and they start to have some neurologic symptoms, some nausea, maybe some vomiting. What do you do? Now, the answer is to rest for 24 hours. So kind of going back to step 1 for 24 hours. Then they go to wherever they were minus 1 step. So this patient was doing moderate activity. And so we'll tell her to rest and then return to light activity. Now, if she were going back to her regular activity or he were going back to his regular activity, we would tell him then to go to moderate activity. So after your mandatory rest period, then you go back to the step you were at minus 1, essentially. Okay, so that's kind of how it works. So I wrote it here. If at any point there are concussion-related symptoms, rest for 24 hours, then return to the previous step. So our answer here was first to abstain from activity for 1 to 2 days, and then when he returns, then he's going to go back to the previous step. All right, so that rather than weightlifting, which is kind of moderate activity, he might go back to, okay, you can walk on the treadmill 4 miles an hour, but nothing more than that. And that's going to be for 1 day, and then you can continue your steps. Okay, question 4. A 23-year-old guy comes into the clinic complaining of 3 days of dysuria. He denies any other symptoms at this time and has no significant past medical history. He's otherwise healthy. He engages in frequent sexual intercourse with both male and female partners and uses protection inconsistently because he does not like how condoms feel. That is so common, by the way, and really irritating. On physical exam, watery discharge from the urethral meatus. Urethral swab is performed and reveals abundant neutrophils with no visible organisms. Which of the following antibiotics is most likely to resolve this patient's symptoms? A. Ciprofloxacin, B. Acyclovir, C. Doxycycline, D. Trimethoprim sulfamethoxazole, also known as Bactrim, or E. Metronidazole. All right, so let's see what the right answer is. It is doxycycline. Now, likely what we are dealing with here is chlamydia. And how do we know that? Now, step 3 likes to do this where they're not asking you for the diagnosis. They expect you to know the diagnosis, and they're asking you something else. Step 2 is a little bit more lenient where they may just ask you the diagnosis. So we know that this is likely chlamydia. That's certainly a non-gonococcal urethritis because, number 1, it's a watery discharge, and gonorrhea tends to be purulent and stinky. And then the dead giveaway here is that there are abundant neutrophils but no visible organisms. Now, in gonorrhea, we would expect to see gram-negative intracellular diplococci. But that's not what we see. We don't see any visible organisms. So we're likely dealing with a chlamydia here. Now, what about these wrong answer choices? Well, ciprofloxacin is wrong because this is typically what we use for a prostatitis. Now, certainly, this guy could be at risk for prostatitis. He has sex with men. If he is an insertive partner, he can get prostatitis from that. Why? Because prostatitis is usually caused from coliform organisms. So E. coli, for instance. And this can happen in older men with enlarged prostates, or it can happen in young sexually active men, or sexually active men in general, who insert their penis into a rectum. Now, I shouldn't say men who have sex with men, because certainly heterosexuals do this too. It's kind of a dirty little secret, but they do it. So don't jump to the conclusion that just because they're men who have sex with men, that they're necessarily doing that, or if they're heterosexual, that they are not doing it. So it's important to bear that in mind. Always important to ask a patient what their sexual practices are. So we generally, with an acute prostatitis, will go for a fluoroquinolone. That could be ciprofloxacin, it could be ofloxacin. It doesn't really matter. Just pick a fluoroquinolone. Acyclovir is going to be used for herpes. That is an antiviral. We do not expect herpes in this patient because herpes will usually present with those painful vesicular lesions, and not with a urethritis. Trimethoprim sulfamethoxazole or Bactrim would be given for a UTI. Now, certainly if this is a CCS question, you are going to get a urinalysis, but UTIs are just not really common in men. And furthermore, we would not suspect it, even though he has dysuria, we'd not suspect it because with a UTI, that is a cystitis, not a urethritis. And so you're not going to get a urethral discharge. And then metronidazole would be used for trichomoniasis. And men can get trichomoniasis, but it's generally asymptomatic, which is unfortunate for women because you don't know you have trichomoniasis, and then you go pass it on to your female partners, and then they wind up with cervicitis. Remember, that's that gray-green stinky discharge that comes from the cervix, and you'd see it on a speculum exam. All right, so, oh my goodness, I already wrote this. All right, so let's go ahead and take a look at the difference between the two. So gonococcal urethritis is caused by Neisseria gonorrhea. Always. The urethral discharge is going to be purulent and often abundant. And it also tends to stink. If you want to smell it, go for it. I personally would not do that, but whatever floats your boat. The urethral gram stain is going to show you intracellular gram-negative diplococci. Please commit that to memory because that may be the only thing they tell you. The treatment here, what treats this is ceftriaxone. Now, if a patient has gonorrhea, we're also going to treat them for chlamydia. So we'll give them ceftriaxone and azithromycin, or ceftriaxone and doxycycline. This ceftriaxone is given as an intramuscular injection, so you only need to do it once. You can do it in the clinic. You see those gram-negative diplococci, and you're done. Ceftriaxone injection, and then send them home with either azithromycin or doxycycline. I don't believe you're going to be asked to choose between the two. Now, non-gonococcal urethritis, remember, is that watery discharge, and there's less of it. The organisms here are multifold. The most common is Chlamydia trachomatis. If you are one of my followers that's taking step 1, remember that those are types D through K. Very easy way to remember that. I'm not going to tell you because it's R-rated. Another possible cause is Mycoplasma genitalium. Much less common, but still out there. Another cause is Ureaplasma ureolyticum. And technically, trichomoniasis is a non-gonococcal urethritis. So, Trichomonas vaginalis. But I'm putting that up here for a reason we'll just get to in a little bit. The urethral gram stain is going to show neutrophils, but that's pretty much it. The treatment here is doxycycline or azithromycin, but I would go with doxycycline on exam if you have to choose between the two, but I don't expect you will. Now, if you're dealing with trichomoniasis, the treatment is completely different. It's metronidazole, as I already mentioned. Now, let's say that this patient came back to you and you gave him doxycycline and he comes back to you and he says, I'm not getting any better. And, I took your medicine, I'm not getting any better. What are you going to do? Number one, you're going to repeat the urethral gram stain. And then number two, you're going to get an NAAT, nucleic acid amplification test. And you're going to get that for chlamydia. You're going to get that for Mycoplasma genitalium. You can get it for Ureaplasma ureolyticum, and you're going to get it for trichomoniasis. And then one of those is going to come back positive, and it's probably not going to be chlamydia. However, if you were using azithromycin and it was chlamydia, now you're going to use doxycycline. On the other hand, if it comes back positive for something else, let's say Mycoplasma genitalium, then your next step is going to be a different antibiotic. And do you know what that is? It is going to be, I'll just put MG here, it is going to be moxifloxacin. And that could get asked. Now, it's not common that this happens, but I would remember that you will use moxifloxacin if you have an infection with Mycoplasma genitalium. Now, finally, I would just add that the typical treatment, if you have gonorrhea, is to do both ceftriaxone and doxycycline or azithromycin. Whereas, if you know that it's chlamydia, then you don't need to use ceftriaxone. You'll just use a monotherapy. And so that is different from the way we used to do it several years ago, where we would always do the double therapy. But if you know it's a non-gonococcal urethritis, you can just do doxy or azithromycin. Okay, let's move on to question 5. We've got an 18-year-old guy coming into the clinic complaining of blood in his urine for the last 3 days. He's got no significant past medical history, but he says that recently he had a runny nose and sore throat a few weeks ago, shortly after returning from a missionary trip in Africa. He says that his symptoms, he says he frequently gets colds in the winter. He says that he started noticing the bloody urine around when his symptoms resolved, but it went away on its own. This week it came back. He is scared that he has cancer, as his grandpa and his uncle both died from bladder cancer. He denies dysuria and is not sexually active. He's on no medications. Vitals show blood pressure 151/99, heart rate 95, respirations 12, temperature 98. Physical exam is unremarkable. BMP is within normal limits. Urinalysis shows 20 to 30 red blood cells per high-powered field, 1+ protein, negative ketones, negative esterase. No casts are visualized. Which of the following is the best next step in the management of this patient? A, serum complement. B, serum ANA. C, cystoscopy with biopsy. D, PT, PTT. Or E, reassurance and send him home. Okay. So we got a young person with hematuria, and it came after a cold. What are we thinking here? So the answer is serum complement. Now let's just stop here, because I made this one of those questions where you have to answer number 1, and then you can't go back, and now there's going to be a follow-up question. This comes up quite frequently on step 2 and 3. So let's move on to question 6. Serum complement reveals a normal C3 and C4. Which of the following is the most likely diagnosis in this patient? A, acute post-streptococcal glomerulonephritis. B, IgA nephropathy. C, bladder cancer. D, urinary schistosomiasis. Or E, renal cell carcinoma. And the answer is IgA nephropathy. Now, what we have here is a young person with a hematuria, and it came after an infection. This is a classic picture of one of two things, either A or B, acute post-streptococcal glomerulonephritis or IgA nephropathy. Now, as we are going to see, although there is a lot of overlap, you can generally tease these two apart based on the history. So, who is this patient? When did these symptoms come on? What is the pattern of the hematuria? That is really, really, really going to help you. Okay, so IgA nephropathy, used to be called Berger disease, is a glomerulonephritis. We don't really know what causes it. We know the pathophysiology to some degree, but we don't really know the etiology. So we know what's going on pathophysiologically, but we don't know what triggers it, other than that there's an association with upper respiratory tract infections, like a common cold, or a GI infection like a gastroenteritis. And this occurs within days of the infection, as opposed to PSGN, which occurs weeks after the infection. IgA nephropathy causes recurrent, painless, and episodic gross hematuria, and that's another big one, episodic gross hematuria. So it comes on after the infection, it goes away, and then it comes on again, and then it goes away, and then it comes on again, as opposed to PSGN, where a few weeks after the infection, it comes on, and it doesn't really go away, but then when it's gone, it's gone. Okay? Hypertension and mild proteinuria are somewhat common manifestations due to the loss of protein. However, the hypertension in IgA nephropathy is not quite as common as it is in PSGN. Now, like I said, IgA nephropathy is commonly confused with PSGN. You can also call it APSGN. And that can also cause hypertension, but in APSGN, edema is more common. There's a lot more protein loss. And we also see hypertension more common. Whereas gross hematuria is a little bit more common in IgA nephropathy, but they really both have it. What's really going to help you distinguish between the two is that in IgA nephropathy, it's episodic. It comes and goes and comes and goes. Now, when it's gone, in the interim between the episodes, you have a microscopic hematuria. So it's just not as dramatic. It's not as visible, but you still have it. Now, the big way to distinguish these two is serum complement, particularly C3, but you can also get C4 if you want. This will really help you because in IgA nephropathy, the complement is normal, whereas in PSGN, it is low. All right, so about 70% of cases of IgA nephropathy are going to resolve on their own, and the remainder will progress to end-stage renal disease in about 10 to 25 years. Now, how do we know what the prognosis is? This is a question that can come up on your exam. I have seen it before. So, there are some indicators of a poor prognosis, and that would be an elevated serum creatinine, which we did not see in this patient, hypertension, which we did see. If you go back here, 151/99, that's quite high. And then persistent proteinuria. So we would want to follow this patient up with a urinalysis, check his blood pressure, and get a renal function tests, because that will help us understand what his prognosis is. So this is just a comparison of IgA nephropathy and PSGN. This is commonly confused, and you will get a test question where if you don't know this, you will be confused. So like I said, IgA nephropathy starts days after an upper respiratory tract infection, basically as soon as the symptoms resolve, whereas PSGN doesn't start until weeks after an infection, and it doesn't come after a viral infection, with limited exceptions. This can also be called post-infectious glomerulonephritis because there are some other causes. Influenza can do it, but it's a lot more rare. And I don't think you will be asked about that. The labs, it's really based on that complement. However, there's another test, an ASO, that is going to be positive when it is post-streptococcal. Now, the patient population will also give you a clue. So with IgA nephropathy, it's commonly teenagers to young adults, like in their 30s. Whereas with PSGN, it tends to be prepubescent children. Now, can it happen in different ages? Of course, but that will give you a hint on your exam question. So I would remember that. The cause, we already talked about. Hematuria, it's really just the pattern. You're going to have it in both. So with IgA nephropathy, it's episodic and gross. With PSGN, it's persistent and gross. And again, when it comes on is going to help you. Edema and hypertension are a little less common in IgA nephropathy. Sometimes they're not even there. With PSGN, they're pretty much always there. The management for IgA nephropathy is supportive. If you're dealing with hypertension, like in this patient, you're going to give ACE inhibitors. Rarely you would use steroids or immunosuppressants. Now, in PSGN, it's pretty much always supportive, but a lot of these patients have some pretty significant edema, you're going to see puffiness around the eyes. And so in those cases, if you're dealing with a child who's very edematous, do diuretics, give furosemide. If you need to deal with hypertension, you're going to go for calcium channel blockers like nifedipine. Prognosis for IgA nephropathy, we already talked about. For PSGN, very, very good prognosis in children. They pretty much all resolve. Adults may progress to chronic kidney disease. And I just want to point out here, well, that's going a little too far back. So our diagnosis here, we were between these two. Bladder cancer is not likely in this patient simply based on his age. And also bladder cancer, you usually have to be exposed to things. So they may throw at you those distractors like grandpa and uncle had bladder cancer, but it's just very, very unlikely given the infectious history and how quickly this came on. Urinary schistosomiasis, yes, he was in Africa, but I will tell you something. With urinary schistosomiasis, they do indeed have hematuria, but it's a terminal hematuria. So they will be peeing and it will be normal. And then right when they get to the end of their stream, they see some blood. That is classic for schistosomiasis. And then renal cell carcinoma, again, unlikely in this patient, simply because of how quickly this came on, the fact that he is a young man. Yeah, renal cell carcinoma can happen in younger people, but again, they're saying the most likely diagnosis. And so when you approach these step 2 and 3 questions, there are going to be a number of plausible answers, but you have to choose the most likely diagnosis. Okay. Question 7. A 62-year-old woman comes to the clinic complaining of a painful ulcer in her left great toe. She says that this ulcer has been present for 3 weeks and she believes it came on after she stubbed her toe. However, it is not healed. She's got a past medical history of hypertension and type 2 diabetes. Medications include lisinopril, propranolol, and metformin. Her most recent A1C 2 months ago was 7.7. What is that? It's a little high, right? That roughly corresponds to a chronic 180 milligram per deciliter glucose. Vitals, she's a little hypertensive. Temperature is a little bit high, but not really super febrile. Heart rate 88, respirations 12. CBC shows a white count of 14.2 and an elevated sed rate. Physical exam reveals a 1.4 by 2 centimeter ulcer on the right great toe with a necrotic base. Blood and wound cultures have been obtained. Plain films of the right foot are unremarkable. Which of the following is the most appropriate next step in the management of this patient? A, MRI, B, CT with contrast, C, bone aspiration and biopsy for culture and sensitivity, D, wound debridement and culture and sensitivity, or E, 3-phase bone scan. Okay, answer here, MRI. So generally the way we go about this is when you suspect osteomyelitis, you're going to get a plain film x-ray. If that comes back positive, you've got your diagnosis, and you will move on to the bone aspiration. So this was probably the most common wrong answer. You got to do the MRI first. And the reason, and of course, you do the x-ray first. If the x-ray comes back positive, you have your diagnosis. If it comes back negative, which it often will, then you do the MRI. If the MRI is negative and it's been more than a week, then consider alternative diagnoses. Not coronary artery disease. Consider alternative diagnoses. If it comes back positive, you have a diagnosis. Okay? So osteomyelitis is an infection of the bone. It commonly starts out as an ulcer, often due to an injury, and then it spreads to the bone. However, it can also arise hematogenously. So you have an infection in your bloodstream, and then it goes to the bone. That is how it commonly happens in IV drug users, whereas in diabetics, it tends to be a foot ulcer. And that is because of peripheral neuropathy. You don't feel things so well. You don't have as good circulation. That's just a recipe for osteomyelitis. The most common cause of osteomyelitis is Staph aureus, and that is because if you get an ulcer, it's going to get contaminated with skin flora. Staph aureus is all over your skin. The best initial step is a plain film of the affected bone. Okay? The nice thing about that is that it's easy to do and you don't expose the patient to radiation. However, it's only about 54% sensitive. That is not good enough. So if that comes back negative, then the next step is to do an MRI of the affected bone. That is very sensitive. And basically, if you have had the symptoms for more than a week and you have a negative MRI, you can rule out osteomyelitis. So always perform this even if the plain film comes back negative. The most accurate test, and you always need to do this, when you have a presumptive diagnosis, so a positive x-ray, positive MRI, is a bone biopsy. You've got to know this. You will get questions wrong if you don't know this. So you will always perform this after positive imaging. It's the gold standard, and there's two big reasons why we do this. Number one, to confirm the diagnosis. And number two, to get cultures. Okay, you cannot get a wound culture to determine what the cause is. It will be contaminated by skin flora. So you cannot do this. Okay, you have to get a bone biopsy and culture. It will guide your treatment. The empiric therapy for osteomyelitis is going to be broad coverage. The big one that you need is vancomycin because it covers MRSA, and MRSA is common. Then you'll also add on a third or fourth generation cephalosporin, so something like ceftriaxone. Have you noticed? We use this a lot. Or you can use cefepime. Okay? A common wrong answer choice is topical antibiotics. It does not work. So we're going to go with IV antibiotics. Okay, so let's move on to question 8. We got a 34-year-old woman coming into the clinic complaining of worsening shortness of breath on exertion and cough for the last 2 months. She's otherwise been in good health and does not take any medication. She's concerned because it's becoming increasingly difficult to play with her kids and to function at her job as a teacher. Review of systems reveals some mild joint pain, which she attributes to being tired all the time. She doesn't smoke or use recreational drugs. She's divorced, lives in Florida, and is not currently sexually active. Physical exam reveals a tired-appearing woman with mild, non-tender cervical lymphadenopathy, diffuse wheezing, and tender erythematous nodules on her shins bilaterally. Chest x-ray is ordered and reveals bilateral hilar lymphadenopathy and bilateral pulmonary infiltrates predominantly in the upper lung fields. She is mildly febrile at 100 degrees Fahrenheit. Which of the following laboratory parameters would best support the most likely diagnosis in this patient? A, biopsy of the skin lesions, B, beryllium lymphocyte proliferation test, C, hypercalcemia, D, elevated angiotensin converting enzyme, or E, increased total lung capacity. All right, so another one of those typical step 3, maybe step 2 questions where you're expected to know the most likely diagnosis and then answer a question from that. And that can be challenging, to say the least. So what do we have here? So the answer is hypercalcemia. What is the most likely diagnosis in this patient? Sarcoidosis. Now, there are a number of other things that it could be. Based on the fact that she's got this hilar lymphadenopathy, but also these worsening pulmonary symptoms. Now let's look at the possibilities here. Could it be an asthma or a COPD? Probably not. It's probably not asthma because these symptoms have been going on for a long time. Usually with asthma, the findings are flares. They get asthma attacks, and then in between them, they're okay. And then COPD, she's not a smoker. Usually with COPD, we see it coming on with people who have smoked for a long time, and then they get it when they're a little bit older. Berylliosis is an interesting one because it commonly is confused with sarcoidosis. Now, this is likely not the case in this patient because berylliosis is usually an occupational exposure. Think of people who maybe do ceramics, they work around metals, maybe they work in the aerospace industry. There's usually going to be some sort of occupational exposure. Certainly she's not going to be exposed to this as a teacher. Then if we think of other possible causes, there's really nothing that fits with this other than sarcoidosis. So sarcoidosis we tend to see in younger women when they present for the first time. So looking at some of these wrong answer choices, the beryllium lymphocyte proliferation test, we don't think that that's the most likely diagnosis, so we get rid of that. Increased total lung capacity, we would expect to see that in COPD, so that is not the right answer. And then we're left with these other three things that maybe they could be useful for diagnosing sarcoidosis, but the best way to really nail down that diagnosis of sarcoidosis is a hypercalcemia. Remember that granulomas make 1-alpha hydroxylase, okay? And that is something that is going to increase your vitamin D and therefore increase your calcium level. So that is really suggestive of sarcoidosis. Now, can other granulomatous diseases cause that? Sure, but those are unlikely. Now, another thing that this could be is potentially a fungal lung infection. But the problem is she doesn't really live in one of those areas that cause or where you're going to be exposed to a fungal lung infection. So we think of maybe something like histoplasmosis kind of in the southern central United States. Think of Kansas, Missouri, Oklahoma, maybe parts of Texas, Iowa. And then there's also blastomycosis, which is commonly found in the north central United States, Ohio, Mississippi River Valley. You might see it in parts of the northeast along the Canadian border. And then, of course, there's coccidioidomycosis, and that is going to be in the southwest. So you don't really see this in Florida, and you don't see a whole lot of fungal lung infections in the northwest. So knowing that geography is going to help, but again, that's not likely the cause here because, again, this only came on 2 months ago. She's got all those pulmonary findings. She's got some joint pain, and we typically don't see that in those fungal lung infections, at least the joint pain and other systemic findings. Now, some of you probably thought D, the elevated ACE, and that does commonly happen in sarcoidosis. But it is not a very sensitive or specific test. So I would not order that as part of the workup for sarcoidosis. Now, tuberculosis is an interesting one. It's very difficult to rule out, but it's just not common in the United States. This would be an active tuberculosis if it was indeed tuberculosis. And she doesn't really have the risk factors for that. We don't know of any sick contacts. She hasn't been out of the United States as far as we know. And on the USMLE, if they don't tell you something, you should not assume that it exists. So sarcoidosis is a systemic non-caseating granulomatous disease of unknown etiology, primarily affecting the lungs, but it can really affect any organ system. So some of the more common ones, aside from the lungs, are the skin. And what we would see there are one of the things that we saw in this patient, which is erythema nodosum. They're not going to tell you erythema nodosum. What they'll probably tell you is painful nodules, and they have a tendency to occur on the shins. So that's a pretty common thing that we can see. We can also see CNS manifestations. You can see renal manifestations. And then these joint pains are also very common. So look for that. Systemic features can happen. They can have fevers, malaise, fatigue, weight loss. That's where you get a little bit of confusion with TB, but you, again, just really look at that patient's history. There's something called Lofgren syndrome, which is a triad of joint pain, erythema nodosum, and hilar lymphadenopathy. That's very suggestive of sarcoidosis. You could add fever to that, and then you have kind of a quartet rather than a triad. But that's Lofgren syndrome. We see it often in sarcoidosis. Hypercalcemia is a characteristic finding on, and I should say, workup. I didn't really put anything there. So be sure to order a calcium level on patients where you suspect sarcoidosis, because that's really going to help you nail down that diagnosis. Like I said, sarcoidosis is usually a diagnosis of exclusion. We look at things like TB, fungal lung disease, and borreliosis. The history is going to help you there. The prognosis, most cases, will resolve spontaneously in 1 to 2 years. Often, this is a diagnosis that you'll make incidentally. You get a chest x-ray for some other reason, you see hilar lymphadenopathy, patient's not really having symptoms, and so you would make that diagnosis incidentally. And in that case, if they're not having symptoms, they're not having shortness of breath, they're not having joint pain, you don't need to treat it. So you just observe, and eventually it goes away. So what I would recommend that you commit to memory is not only how this is diagnosed and how this presents, but also the prognosis, because you can get those questions on step 3 where they ask you, what do you tell the patient? And what you would tell the patient is, this does go away over time. Now, can it persist? Yes, but in about 3/4 of cases, this goes away over time, about 1 to 2 years. Now, if the patient has symptoms, like in this patient, joint pain, ocular manifestation, difficulty breathing, then go ahead and give glucocorticoids like prednisone. If that doesn't work, we can look at things like methotrexate and infliximab, but that's not where we start. This is an example of the pulmonary findings that you may see. All we see here is lymphadenopathy. This is hilar lymphadenopathy. Look for those opacities around the heart. This is lupus pernio here, and it looks a lot like the malar rash that we see in SLE. It's really, really hard to tell the difference. Just go by clinical history. Lupus, I would look for lupus in this patient. If somebody came in with a face looking like this and joint pain, definitely get an ANA in this patient. And by the way, tuberculosis, sure, get a Mantoux test. But this question was asking, what's the most likely diagnosis in the patient? Now, when you're doing CCS, you're not just thinking of the most likely diagnosis, you need to consider your differential. But on the multiple choice questions, you've got to narrow it down to one possible diagnosis. This here is erythema nodosum, absolutely not specific for sarcoidosis. You can see it in a variety of disease processes, but again, it's just another one of those things that contributes to sarcoidosis being most likely here. Okay, question 9. We got a 32-year-old man coming into the ED with his girlfriend due to sudden dizziness and confusion for the last 3 hours. His girlfriend says he's really healthy and he runs 5 miles every day. He was recently promoted to chief sales executive at his work and recently started a medication to help him with his jitters, as he frequently has to speak in front of large audiences. He took the medication for the first time today, and his boss called his girlfriend as he was not acting like himself. Vitals show blood pressure of 93/60, heart rate 52, respirations 12, temperature 98.6. EKG shows sinus bradycardia. Focused physical examination reveals bradycardia with no murmurs, diffuse wheezing, and obtundation. Remainder of the exam is normal. Fingerstick glucose is 72 milligrams per deciliter. Urine toxicology screen is pending. Which of the following therapies is most likely to resolve this patient's symptoms? All right. So, what is the answer here? Glucagon. All right, so this is a tough one. And it's tough because, again, it's one of those step 3, but it could be a step 2 question that requires you to know the medication, but then to know the antidote. And it's not telling you the medication. Now, on step 2, more likely, you'll be told the drug and then be asked for the antidote. With step 3, they're going to expect you to infer the drug and then know the antidote. So what kind of drug is this patient on? Well, he was put on a medication to help him speak in front of large audiences. What is that? That's performance anxiety. What drug do we give for performance anxiety? We give propranolol. That's a beta blocker. Okay, it's really good for performance anxiety, for public speaking anxiety. And so this patient is on a beta blocker. And what we see here is that he has beta blocker toxicity. Why? Because he's got hypotension, he's got dizziness and confusion, and he's got a slightly low glucose, so not quite hypoglycemic, but getting there. And then he's got some wheezing. And as we know, beta blockers can cause spasm of the bronchial muscles. So And put this all together, this is beta blocker toxicity. And the management of beta blocker toxicity is glucagon. So that is what we're going to give this patient. Now, fameprazole A would be given if a patient were to have ingested ethylene glycol, for instance. We do not suspect that in this patient. Naloxone would be given for a patient who overdosed on opioids. We don't expect that in this patient because there's no indication that he's been put on a drug for pain. Flumazenil would be given for a benzodiazepine overdose. Could you put somebody on benzodiazepines for anxiety? Sure, but not it's not first line for a performance anxiety. And then insulin and glucose would be given for a calcium channel blocker overdose, but that is not given for a performance anxiety. We give beta blockers, particularly metoprolol or propranolol. Okay, so there are a number of toxidromes that you need to know for your exam, and you should know the presentation, and you should also know the people that are susceptible to them. And I'm not going to run through all of these, but these are some of the ones that you need to know. Now, a lot of students focus on drugs of abuse, and certainly those are important, but you also need to know the toxicities of prescription drugs. So things like calcium channel blockers and antihyperglycemics and certain environmental exposures like carbon monoxide. So it's important that you know these. And like I said, I'm not going to run through all of them, but I do want to point out that beta blockers and calcium channel blockers, when you're toxic from them, they have a very similar presentation. The difference is with beta blockers, you will tend to get a hypoglycemia, and with calcium channel blockers, you'll tend to get a hyperglycemia. But I don't expect they'll ask you that. It'll be apparent based on the history. This requires you to know a little bit of psychiatry and know the first line drug that we go to for performance anxiety. And then, of course, make sure you do supportive therapy for any of the critical symptoms. That's also important as well. Okay, let's finish off with question 10. Last month, your 20-year-old female patient presented to the ED with chest pain, shortness of breath, and dyspnea. While in the ED, swelling of the left calf was observed, duplex ultrasound was performed and revealed a deep vein thrombosis. She was stabilized, appropriately managed, and discharged. Upon review of her records, you find that prior to her event, she had been seen by her OBGYN who had began her on levonorgestrel ethinyl estradiol. This was discontinued immediately after diagnosis. She was previously healthy and had never been a smoker. She mentions that her aunt had a similar event 30 years ago after she started the same medication. Which of the following is most likely present in this patient? Is it A, mutation of the factor V Leiden gene, B, low levels of protein C, C, mutation of the prothrombin gene, D, high levels of homocysteine, or E, the patient is lying about not smoking? Okay, so what is the answer? It is A, mutation of the factor V Leiden gene. So what's going on in this patient? She started an oral contraceptive, and then shortly after that, she had a thrombotic event, deep vein thrombosis, and then she got a pulmonary embolism. So anytime you start an oral contraceptive and you have some sort of risk factor for clotting, and that also includes being a smoker, then what's likely going on is there's some sort of condition that's there, okay? So oral contraceptive and then develop a clot, there's something going on there. And usually it's smoking. However, I have faith in her OBGYN that prior to prescribing the oral contraceptive, he or she asked about her smoking history, whether or not she's currently a smoker. So I would not suspect that that's what's behind it. Now, patients do lie, but on your exam, I would not assume that, unless maybe you're dealing with a psychiatry question, but I would not assume that. Now, this just requires you then to know what is going on as far as the inherited thrombophilia. And we know it's inherited because her aunt had the same thing happen. And so then you just need to know what's the most common inherited thrombophilia, and that is a factor V Leiden mutation. Now, there are others. So protein C deficiency, a prothrombin mutation, those are thrombophilias, but they are considerably less common. About half of inherited thrombophilias are from the factor V Leiden mutation. Now, high levels of homocysteine, that can be acquired through dietary deficiencies, or it can be inherited through an MTHFR mutation. That's quite less common. And then the patient is lying about non-smoking. We already talked about that.